the Health Subcommittee and serves as the co-chair of the Health Disparities Task Force, along with Representative Yvette Clarke out of New York. We are truly appreciative of the Honorable Dr. Robin Kelly. Thank you so very much for joining us today as we talk about your report. We also have with us another person who I had the pleasure of coming up under and admire consistently, Dr. Nadine Gracia, who serves as the Chief Operating Officer of Trust for America's Health. Prior to this role, which she holds and I certainly hold in such high esteem, she served as the Director of the Health and Human Services Office of Minority Health, and that's where I initially got to know her. We're so excited that you bring words to us today, Dr. Gracia, and I'm very much looking forward to just picking your brain in addition to this esteemed panel. Thank you for joining us today. Another one of my favorite people, person of the health world and just in general, is Daniel Dawes, who joins us as the director of the Satcher Health Leadership Institute at the Morehouse School of Medicine, which of course is named after the esteemed Dr. Satcher. And he is going to talk to us about a number of things, but I also just have to shout out that he is the author of two books that I think everyone should really have on their shelf, 150 Years of Obamacare, and then also his most recent book, The Political Determinants of Health, which has a very long subtitle, and I'll just let him tell you about that another time. And then last but not least, my friend and cohort fellow of the NMQF 40 Under 40 Leaders in Minority Health, Dr. Brian Cameron Webb, who joins us today from the University of Virginia School of Medicine. And if you don't yet know, although most of you do, he is a candidate for Congress running out of the 5th District of Virginia. But he's also still a practicing clinician. He's a husband, a father, and he does all the things. So I don't know how he's, well, I do know that he has all the energy in the world. And so I appreciate him lending time for us today. Thank you all for coming through. And as I should let our audience know, each of you is a contributing author to the Kelly Report. And I would be remiss if I didn't invite Congresswoman Kelly to just tell us a little bit about how the report came to be. How did you come to conceive it? What were you inspired by? What was your process? And if you can explain the significance of the report today and then as well. We can't hear you, Congresswoman.
You would think I would know how to do it by now, but good morning, everyone. Thank you, Mia. It is wonderful to see you. Of course, my forever healthcare senior policy advisor. And also it's an honor to be with all the panelists. I've worked with Mr. Dawes and Dr. Gracia, and I have plans for Dr. Webb when he joins me as my colleague. And you know what I mean, Mia. But it's an honor to be with all of you today. And I just feel really honored that we're discussing the Kelly Report that all of you were such a big part of. It's just so hard to believe 5 years has even passed. But when I look back at it, we've been talking a lot about it lately because of COVID and maternal mortality, which wasn't even in the report, you know, but I've done so much work around that thanks to Miss Mia. But the report is still pertinent. You know, we kind of wondered if we should even, you know, talk about the report, but COVID has shined such a light on healthcare disparities. The numbers are shocking, but not surprising. We know that, you know, these disparities have been around, I won't say for a long time, I'll say forever. And we just haven't done, you know, enough about them. But first I have to credit Marsha Fudge for appointing me to be the chair of the Brain Trust. And then I have to credit my staff. I have to credit, you know, my Brandon Garrett and Brandon Webb, because they, you know, thought about this. We talked about it. We wanted to do something really impactful and significant, and under their guidance and leadership and other staff, you know, this report was conceived, but we felt we needed a baseline to operate from. And we really needed to hear from the experts, you know, what was going on, what wasn't going on, and what needed to go on. So that's why I was pleased that the report not only talked about the problems, but it talked about solutions also. And there are, even though it's been tough because of people how Congress was made up. It was hard to get, things passed, but we're slowly, moving on that. The Action for Dental Healthcare passed, which was in the report. And then recently I was able to get more money for the study of gun violence into the CDC. So, and there are other things too, but really that was our inspiration. We wanted to make a difference. We wanted to create a baseline so we could see what, our progress was. And we wanted to hear from the real deal, the professionals. And I thank them forever.
I do too. And, I want to invite all of them, Congresswoman, to basically share, what they're doing now. And then also, what they contributed to the report and what it means for the current day. And so I'll invite Dr. Gracia to open up with that.
Thank you, Mia. And as you said that you are an admirer of us, we are an admirer of you, and really appreciate having this opportunity to be on this panel, certainly with Congresswoman Kelly and with dear friends, Daniel Dawes and Cameron Webb. It's such a pleasure to be here with all of you. And truly, yes, unbelievable that we are here at 5 years after this important and really landmark Kelly report. Thank you, Congresswoman Kelly, for your leadership in really leading us to have this effort, which continues to be such a relevant and important framework and document as we work to address health disparities and advance health equity for the nation. As Mia stated, my name is Nadine Brasi. I serve as the Executive Vice President and COO at Trust for America's Health, commonly known as TIFA. We're a nonprofit, nonpartisan public health policy research and advocacy organization, and we're based in Washington, D.C., where we focus on really presenting evidence-based recommendations to promote optimal health for every person and community, and where our vision is that we will have a nation where prevention and health equity are foundational to policymaking, really at all levels of society, that we can instill and see certainly a nation where the policies that we set forth ensure that everyone has a fair and just opportunity to reach their full potential for health. And certainly happy to talk about more of the work that we address, but in particular focus on prevention in public health and looking at how we can strengthen systems, and in particular the public health system, to address and answer the 21st century public health challenges that we face, and doing so in a way that's scalable, that's sustainable, and that really ensures that the population as a whole benefits, but that we center equity in our efforts. In my role with the Kelly report, at the time, I was the Deputy Assistant Secretary for Minority Health and Director of the Office of Minority Health at HHS. And we were at the time in the Obama administration experiencing a confluence, I think, of anniversaries too with the Kelly report. It was the 30th anniversary of the report of the Secretary's Task Force on Black and Minority Health, and also the 5th anniversary of the Affordable Care Act. And so what I wrote in the Kelly report was really talking about the historical importance and the movement and journey of minority health and health equity in that frame. And for those of you that aren't familiar with the report on the Secretary's Task Force on Minority Health, on Black and Minority Health, which is commonly known as the Heckler Report, it was the first time that the federal government had brought together and convened a group of senior level experts to study the disparities that existed among racial and ethnic minorities. The first time that the government issued a report documenting those disparities, which found that 6 disease conditions actually contributed to more than 80% of mortality among people of color. And it was that report that catapulted and really brought minority health onto a national stage from a federal perspective. And I say that from a national stage from a federal perspective is because for years, researchers and advocates had known that health disparities were happening. There was literature there, but the federal government had not yet documented it in such a comprehensive way. And we had the leadership of leaders from the historically Black medical colleges and others who really advocated to Secretary Margaret Heckler at the time that there was a need for the government to do such a report and documentation. And that report then led to the creation of the HHS Office of Minority Health as one of the most impactful outcomes of that report. And what we can see over the years is really important advancements in legislation, in policies, in programs, in data, and in research and infrastructure around the country to advance minority health and to address health disparities and health equity, and certainly leading to the Affordable Care Act, which was one of the most transformative laws really to help us in addressing health disparities, which I know that Daniel has a whole book on in describing that timeline and the impacts of the ACA. But in the chapter that we wrote was also to highlight the important disparities and equity provisions that the ACA addressed, from coverage to access to care to quality of care to the workforce to data and research, that all of these things were so instrumental with regards to how the Affordable Care Act was going to continue us on this journey towards achieving health equity for the nation.
Thank you so much for that, Dr. Gracia, for laying that out. And as you mentioned, for those who have not yet read the Heckler Report or aren't yet familiar with it, we'll get it up in the chat so that after this panel, or really after this day, because we want you to go on, audience members, to the other panels, to go and read the Heckler Report, become familiar with it. And then, of course, we've linked to the Kelly Report. Thank you for that, Dr. Gracia. I do want to invite Daniel to talk a little bit about that. A lot of what he has to say certainly complements what Dr. Gracia brought together. So tell us, Daniel, what you're working on now and what your contribution had been to the Kelly Report.
Absolutely. Well, thank you so much, Mia. And let me just say that, ditto everything that Dr. Gracia just mentioned. I think what she laid out is what I intend to build on. But before that, let me also recognize you, Congresswoman Kelly, for the incredible leadership that you've exercised in advancing health equity in policies. And we thank you so much for all that you've been doing. I am excited to join this panel. I was sharing with Mia last night, in fact, how excited I was to see Cameron Webb, Dr. Webb, and Dr. Gracia on this. So it's a great panel, and I'm so honored to join you all as well. Let me start out with a little history lesson as well, since Dr. Gracia was going through a timeline. So for more than 40 years has passed since the federal government held its first ever congressional hearing to specifically address minority health and health disparities in the country. During that 1979 hearing, policymakers highlighted the diminished quality of care afforded racial and ethnic minorities, the lack of diversity in healthcare workforce, and the poor health outcomes among lower socioeconomic status individuals and minorities. Doesn't that sound familiar? 40 years later, right? So one of the most striking points from that congressional hearing was and the ensuing report that came out of it was that although a full commitment to equality has never characterized American health policy, serious questions arise whether the present partial commitments to equality in healthcare will be maintained. Think about that for a minute. So it's, while it's shocking to read the unequivocal acknowledgement that we've never experienced a full commitment to health equality in America, even more concerning is that health equity leaders in 1979 doubted that even the limited gains they had achieved would be maintained into the future. They were right. When Congresswoman Kelly convened us in 2015 and invited articles on various health policy topics, I think many of us were optimistic that we were turning a corner in health policy, one in which we could see and feel more than a partial commitment to health equity. And it's that drive to realize a full commitment to health equity that drives us at the Satcher Health Leadership Institute at Morehouse School of Medicine. It's the reason why we've been working diligently to research, understand, and address the determinants and the drivers of health inequities, especially as we try to help our communities not only survive this pandemic, right, but thrive during this triple pandemic that we're experiencing. Never before have we as a country been able to achieve an equitable response to an epidemic or pandemic. And it's always the same group of people who've been on the downside of advantage and opportunity who've been most negatively impacted. Think about that for a minute. Never in United States history, and as a congresswoman was mentioning, during this COVID pandemic, this has magnified the inequities, but never before during a pandemic have we been able to realize an equitable policy response. I believe, though, that this moment in history is our opportunity to change that. And with collective action, I believe that we can realize meaningful, impactful, and systemic changes moving forward. And I'm looking forward to having that discussion.
Daniel, you always bring the good energy, and we're so excited that you're here with us. Thank you for laying that out. And so we want to invite Dr. Webb Cameron. Tell us a bit about what you're doing now. Of course, all of us can guess, but give us a bit of insight, and then talk to us about your contribution also to the Kelly Report and what it means to you.
Absolutely. Well, first I'll say it's a pleasure to be here with a lot of my heroes. Between Dr. Gracia, between Daniel Dawes, the inimitable Mia Keys, and Congresswoman Kelly. I think all of you have had a big role in kind of influencing me over the last years, especially these years since the Kelly Report. And Congresswoman, it's so great to see you, and thank you for all of your leadership in this space. It's the reason why people believe that I can have an impact in Congress working on health disparities, because of the ground that you've laid, the groundwork you've laid over the last several years. I think that I'll start off with where I was in 2015 and in this Kelly Report, because at the time I was still in my residency training in New York City, and I had finished my medical and law degrees, and had been interested, passionate about working on health disparities, on health equity for years. And it was during law school that I saw the Affordable Care Act as one of the best opportunities for us to address health disparities, health inequities in years. And we saw that opportunity, and we said, well, access to care is going to be a big component of that. So my contribution to the Kelly Report was on access to care as a social determinant of health. And a lot of times people will say, well, is healthcare access actually a social determinant? And it absolutely is definitionally, if you look at the fact that it's shaped by social policies. And so we look back at the Affordable Care Act, and we talk about it as landmark legislation. We talk about 20 million Americans gaining insurance. But the fact of the matter is we still have nearly 30 million Americans who don't have insurance. And who are those 30 million Americans? Well, disproportionately, they're Black and brown. Disproportionately, as persons of color, they are distanced due to social policies from access to healthcare. And we tried to articulate that, try to describe that in the Kelly Report in 2015, using a framework that described kind of the different dimensions of access to care. I think a lot of times people think of access to care as solely holding an insurance card. And that's a really important part of access to care, but it's not the only one. And I think that if we limit ourselves to thinking about insurance status, then we're going to miss the reality, all of the social factors that drive folks to not actually have true access to care. And so it's things like the approachability, acceptability, the availability and accommodation of care, the affordability, and then finally the appropriateness, all of those things. And of course, like any good idea, it has to all start with the same letter. But I think what was interesting about it was just really thinking about it from the provider side. These are the things we need to be tending to if we want to ensure real access to care. And so, it's while it was exciting with the Affordable Care Act in 2010 to see that, hey, we were going to be expanding access to care, I think the work remains undone. And that's kind of what brings me to where I am today. I finished my residency training and actually went and worked in the White House. I worked for President Obama in 2016 on the White House healthcare team. This is during a year as a White House fellow. So I worked both on the White House healthcare team and on President Obama's My Brother's Keeper initiative. So there I was, working at that intersection of health and social justice, trying to, again, be like my hero, Nadine Brasi. And I think that along those lines, I really saw that, hey, those 23 federal offices and agencies that I was working with every day as a part of the White House, I said, these are the levers, these are the tools that we need to use to actually deliver health equity. And so, what was interesting about my White House fellowship year is that it's a nonpartisan program, and I spent the second half of my fellowship year in the Trump White House. And so you can imagine the whiplash that I experienced, but pretty quickly, what I saw was that this was an administration coming in that did not have the same attention or even thoughtfulness around health inequities. And in fact, seemed to be, quite ignorant on the nature of those inequities, or at least willfully and wantonly negligent when it comes to acknowledging them. And so, a lot of the work that we aimed to do was to elevate that conversation, bring folks into the White House who could help this administration understand exactly why it was critical that we continue to expand access to care. In the years since then, I've gone on to the University of Virginia, where I'm the Director of Health Policy and Equity here at the UVA School of Medicine. I still work clinically as an internal medicine doctor. I'm a hospitalist, and that means since March, I work on the coronavirus unit at the University of Virginia. I'm actually working there tonight, so no rest for the weary. But I think that for me, what we see is this is such an incredible moment for us to get this right. This election matters a lot. And I'm not just saying that because I'm running. This election is really our opportunity to get back on track to moving toward health equity. And I'm excited to continue that conversation today.
We're excited. We're definitely excited that you're a part of this conversation and for everything that you're bringing to the world in this moment. Cameron, thank you so much. I'm wondering, Dr. Gracia, because I want to ask you two questions. One, we've been throwing around some language, and so I'm hoping you can help us to level set. We're talking health disparities and health equity and health inequity. Can you just give us a brief definition of what to use and when and why?
A great point to level set. Certainly when you're speaking of health disparities, one is to be clear that it's not just a difference, but that it's a difference that's really associated with disadvantage, with social, economic, environmental disadvantage, and that it's preventable and avoidable, and that there's an element of fairness and justice with regards to seeing health disparities. Health disparities can be a way to actually measure progress. So you can see, are you actually closing the gaps as it relates to specific health outcomes? And then that can be a way to actually measure progress. But it can also be a part of a plan and a strategy really for achieving health equity. But we know that just talking about disparities is not sufficient, that we actually are working to strive to achieve health equity. And in that regard, health equity being ensuring that everyone has a fair and just opportunity to reach their full potential for health. And in doing so, that we're actually looking at the barriers and the obstacles to health. And as Dr. Webb just spoke about, those barriers and obstacles certainly relate to access to care and the quality of care, as well as looking at other social determinants, issues such as poverty, discrimination, lack of access to good jobs, lack of access to quality education or poor quality housing, that all of those factors really contribute to structural drivers that create health inequities. So as we work to achieve health equity, which is both a journey and a destination, we have to actually also focus on not only what happens within the health sector, but also what happens in other sectors as well that certainly serve as structural drivers of health.
Let's talk about that. I really appreciate you mentioning that health equity is the journey as well as the destination, and it operates differently. The strategy itself should operate in the same vein or toward the same intention, irrespective of sector. And you know about working across different sectors. And, as you mentioned at the time of the Kelly report, you were the director of the HHS Office of Minority Health. But today you're amongst the leadership of Trust for America's Health. So moving from the public sector to, really in terms of your career, from the clinical setting to the political realm, and now you're in a prime research-based entity. So Dr. Gracia, how do you think about the ways that these sectors come together with respect to acknowledging and tackling health inequities?
Well, one, in order to actually achieve health equity, we have to actually break down those silos and work across these sectors and work in partnership with these sectors to be able to achieve health equity. I approach each of those roles as having equity as core and the compass and the mission of what I do. So regardless of the sector, it's how do we ensure that we're addressing who is actually suffering disproportionately and why, and getting at the root causes for those inequities. And there's a role for the public sector to play. There is a role for the nonprofit sector, which I'm currently in, to play, as well as certainly the healthcare sector and other sectors such as housing and education and transportation and others. Because we understand, again, that when you look at those social determinants, the significant influence that they play with regards to health status and health outcomes. I would say that we can look at certainly what's happening now within the context of the COVID-19 pandemic, as everyone has alluded to, how much it has starkly shined a light on the health inequities that we see across systems in our country, and that this is not new. We can look at past public health emergencies, whether it's hurricanes or the health effects of climate change, to issues like incidents like the Flint water crisis, and we see the disproportionate impact that communities of color and low-income communities experience as it relates to these public health emergencies. But when we then think about how to actually address these types of inequities, it's really strengthening the systems and ensuring that there aren't inequities that are already baked into these systems from longstanding policies and insufficient resources that are in these communities. We look at the COVID-19 pandemic and certainly can talk about the disproportionate impact as it relates to the number of cases and hospitalizations and deaths that are happening in communities of color. And we can also look at the economic impacts that are happening as well, where people of color are disproportionately in the front lines of working in the front lines of this pandemic in jobs that have been deemed as essential jobs, but also have less likely to have some of the worker protections like access to paid sick leave or to be able to have a good paying job that can actually meet the needs of their families, to then looking at access, for example, to the issues of education and educational equity, and where we're seeing concerns with regards to youth of color being able to have access, for example, to even just broadband to be able to continue to engage in their educational studies. So as we think about the opportunities to really advance health equity, a key aspect of that is that it needs to have a multi-sectoral approach to being able to address the inequities that we see in communities of color. And that has to happen at all levels, at the federal, state, and local level, to be able to ensure that everyone really has opportunity. And we find that it's when you actually break down those silos that you actually can see more of that type of transformative and sustainable change. And when you have meaningful, authentic engagement of communities who have a voice and a seat at the table to help drive those solutions, that you'll see the most impactful and long-term and systemic change.
I definitely appreciate that. And your emphasis on multi-sectoral couldn't be more salient to this conversation. I mean, you yourself are representing a nonpartisan research organization. Daniel's here representing the academy and science. We have Dr. Webb, who's with us, from the clinical perspective, but then also stratified across political zones. And of course, Congresswoman Kelly bringing the policy and political perspective. And so my next question is for both Daniel and the Congresswoman. Daniel, in a couple years back, around the time of the release of the Kelly report, you had also just released your book and a number of other works, but your book, 150 Years of Obamacare. And so the ACA is still the law of the land. And so what I'm wondering from both you and from the Congresswoman, is the ACA enough? And specifically, where do we go from here with respect to the needs of our nation, the way that Dr. Gracia has beautifully laid out for us?
Yeah, thank you for that question. So let me start off by urging everyone to do their part to ensure that the ACA remains the law of the land. I can and will write sign-on letters and amicus curiae briefs until my hand cramps up. But if we don't speak with our votes to ensure compassionate judges and leaders are in power, it will all be for naught, as we know, right? So while we have to fight to protect the ACA, there's always room for improvement. Yes, the ACA is the most comprehensive and inclusive health law post-Reconstruction that employed an equity lens in its development and implementation. And yes, it contains 62 health equity focus provisions that survived that brutal negotiation process. But a significant number of them were not allowed to be implemented. We know all too well the negotiations and concessions that had to be made in order to get the ACA across President Obama's desk. We know them. And we thank the Congressional Black Caucus for really leading that charge. And it's in these concessions that I think there are opportunities for improvement. So I personally believe that the spirit of the ACA was to improve the lives and the health of all, right? By increasing access to quality care and reducing the burdens associated with such. It's that spirit that we should continue to strive for. We should keep pushing for increased access and decreased cost burdens. And we should keep pushing for increased access for the most vulnerable. We should keep pressing to use an equity lens to our policies as we are developing health reforms moving forward. And since the time that we managed to pass that important health law, there has been increased attention to and acceptance of the social determinants of health. You heard Dr. Webb mentioning that, you heard Dr. Gracia mentioning these pesky determinants of health. So I hope we'll be able to, in the next Congress, work on another major health reform policy that will tackle those root causes and drivers of health inequities. I think we can venture further upstream than we did in the ACA, building upon those incredible and important reforms that took us about 150 years to realize.
I couldn't agree with Daniel more. I think that when the bill passed, and I wasn't in Congress then, that no one thought it was the perfect bill or that it was the end all to be all. Everyone thought it was a great start, a great foundation. And like was said, he had to leave the negotiations. He had to leave so much, off the table so he could get something passed. But I think that I don't want to be too political, but if things change, I think we'll see change, and we'll see, after all, Vice President Biden was in, part of the administration. So I think that, we'll see a strengthening of the ACA. 5 years being in Congress in the minority, we kept trying to make changes. We kept trying to improve it, but we just weren't given the opportunity. And now, even though we're in the majority, it's the same thing because we can't get things passed in the Senate. So, if again, things change, if people, vote with their, use their vote to voice what they think should happen, then I think we will see some changes. And I think that Vice President Biden, he had his healthcare task force, which I was on, and it was 8 people with different views. But I think there was a collaborative spirit, and that people want to see more people covered. They want to see it cheaper. We have HR 3 lowering the cost of prescription drugs. We've talked about surprise billing and different things like that. So we were able to talk about a lot of things as Congress, but not necessarily, we could pass them out the House, but not, pass them in the Senate. So that's one of the problems. And we do have the working group in energy and commerce that people are excited about, and not just on healthcare. It's really across the board on energy and commerce. And one thing, these are all the medical professionals on the panel, except for me. And when you talk about the social determinants of health, I say the social determinants of life, because it really dictates how you live, how long you live, and how healthy you live. So, thanks.
Yeah, I truly appreciate that, Congresswoman. We do use the terminology social determinants of health, but everyone's impacted by them, right? The takeaway ought to be the social determinants of health inequities really do render populations that have historically been vulnerable and minoritized and marginalized to not be able to live out most optimally, right? And so that is, I appreciate you making that point. I'm wondering really quickly before I ask Dr. Webb a question, can you tell us a bit more about the working group, what the role is so far, what the purpose is, and what the goals are?
Well, Congresswoman Yvette Clarke, who I'm the co-chair with on Black Women and Girls, she called me as a Brain Trust chair to talk about starting a working group or a task force to really look at the disparities, the inequities, and how do we again build a foundation around that. We were thinking just health, but then Chairman Pallone of ENC threw it back at us and said, no, it's not going to be just health. It's going to be throughout the committee. So the environment, energy, communication and technology. I have legislation around telemedicine. So, as you know, everything interweaves together, and so we're looking at all of those. All of the chairs, co-chairs, or chairs of the subcommittees are a part of the committee than anybody else that wanted to be. So we're trying to build, it was really around COVID and then future pandemics. How do we prevent this from happening? Where Congressman Clarke lives, that was the epicenter, of COVID. But how do we look at each, sector and see what we can do to eliminate the disparities, or if you want to say it the other way around, to get health equity. So we just had a couple of meetings. We just recently met with the CDC about some of the things they're doing. And it's also about holding people accountable for what they say they're going to do and what they're supposed to be about. And also looking at, we haven't really talked about this yet, but diversifying the healthcare pipeline, you know, which is so very important. And looking at who's being hired, you know, who's being promoted once they're hired, you know, and those kind of things. So we're really looking at all the spheres, I guess. But again, we know we won't be able to pass anything probably until January or February.
Yeah.
Oh.
That's real. I mean, the 117th is coming just around the bend. And to your point about sectors, we can't have the conversation around advances in health and medicine without acknowledging where people start and how they're trained to think about medicine and inclusion. And so this question really is for you, Dr. Webb. You know, medical education is not historically inclusive of political advocacy, of teaching around how physicians can become politically involved. And it doesn't often infuse policy with the practice of medicine in a way that policy is valued, right, in medical education. So I'm wondering, as a practicing physician, how do you reconcile your clinical work with your practices in equitable policies promotion?
Well, the shortest answer is I bought down a lot of my clinical time to spend the time working on social determinants of health, right? There's a currency in academic medicine, and you have to put your time where you feel like you can do the most good. Now, in my role as Director of Health Policy and Equity at UVA School of Medicine, I lead all the teaching on health policy. So I teach the courses to medical students and public health students on public health, or on health policy, but also I teach them all the coursework on social determinants of health and health equity. And I think that by bringing those two together, I think the students really recognize the connection between them. So I teach a semester-long course on the Affordable Care Act for public health students. And we really break the law down into 13 parts and really discuss every different aspect of the law. We even reference Daniel's book. And I think that it's really important to have that kind of perspective. And at the same time, I teach a class that I'm teaching this semester called Place Matters. And it's it's a seminar in health equity. So last week we talked about housing, the week before that, food insecurity, you know, and then this week we're talking about transportation, we have land use, zoning, we really go into all these different aspects. And so I think it's so important to dovetail those things, to bring them together and talk about what we mean. You know, I think that in medical spaces, you're absolutely right, that wasn't historically the teaching, but the transformation we've seen in academic medicine, even in the decades since I finished medical school, is significant. I think the students coming in, they're hungry for understanding a lot of those concepts. So it's important for us to meet them where they are. I've got a group of students here at the University of Virginia who are absolutely changing the way that our tests, the questions are written, because they realized there was bias and stereotyping in the questions that students are receiving in their medical education, because it always frames the Black patient as having HIV and AIDS or having some kind of substance use disorder. And I think that they realized, hey, you're priming people to have bias, right? And so how do we redesign medical education to eliminate that? So and that came from the students. And so I think that we're in a different moment. It's how do we use that moment? In medicine, we talk a lot about kind of the hidden curriculum and that experience that you have when you get to clinical spaces and you start hearing from the more senior folks that you're training under, oh, well, this patient has this going on, or they're a frequent flyer because of this reason, not understanding or contextualizing patients within place and within those social determinants. So I think it's really important that we lean into this moment and improve medical education. I think ACGME recognizes that. That's kind of our governing body on graduate medical education. And they've started to tuck in more expectations for teaching on health policy and health equity for medical students. And so it's a matter of seizing the moment and keeping it elevated. But we always say it's the next generation is going to save us, right? It's important for us to invest in them, because I do think that they're primed to really elevate these issues.
Mia, could I just jump in? I think, we've worked 3 years on maternal mortality, and what Dr. Webb just said is just so prevalent when it comes to what we see there and how Black women aren't listened to. And you hit the nail on the head. I just had to say that.
Absolutely. pain management.
Please go ahead. Yeah, Cameron, go ahead.
You know, we watched the opioid epidemic unfold, and people wondered, well, why was it affecting white Americans differently than Black Americans? And we said, well, that's disparities, right? And folks didn't understand it at first, but we said, well, listen, we don't treat Black pain. We historically don't treat Black pain because we're concerned that they're going to be the drug abusers. And so we let them languish. But in reality, it was a disparity that ended up being somewhat protective early on in that opioid crisis, because for white Americans, we were just passing out opioids, you know? And I think that the truth is that neither is the way that we should be delivering medicine, but it helped us understand the way that we do have a very race conscious practice of medicine, even, you know, subconsciously. That's why, you know, I helped lead some implicit bias training at the University of Virginia, because there's a lot of bias among physicians. And I think that addressing that, you know, physicians don't like to hear there's a lot of bias among physicians, even though it was in that IOM report, Unequal Treatment, almost 20 years ago now. That was 2002, right? And so we've known it for a long time. That's what got the headlines, was bias among physicians. But today, you know, when you tell physicians, hey, there's bias, and you make them take the implicit association test, they're just like, okay, you got me. There's some bias, and it's at least the same levels as the public. The impact of that bias is different because of the agency that providers have. And the same is true with law enforcement. The same is true with educators. The impact of that bias on other people is what we need to correct. And that's the reason it's all the more important to have that awareness. So yeah, just wanted to add that bit. It definitely resonates in our care, maternal mortality, you know, pain management. We've seen it in so many spaces.
No, absolutely. I mean, between what the two of you have just mentioned, it's very apparent that the side of change is certainly at the medical education level, but then our policies have to support a lot of the changes that save lives, that preserve lives. And so I want to bring Daniel into the conversation and talk to us about, in that way, how policy, how politics, in a lot of ways, determines health, right? So we've already talked about social determinants of health, but Daniel, you wrote a book recently called The Political Determinants of Health. What are they, and why is that lens, in addition to the social determinants of health lens, critical to today's discussion?
Yeah, thank you, Mia, for that. So, you know, we've been talking a lot about the social determinants of health, and I really appreciate Congresswoman Kelly's take on it and trying to move us to talking about the determinants of life, right? There is no denying that, you know, during this COVID-19 pandemic, it's changed everyday life for all of us in a multitude of ways. But for those individuals who have long been discriminated in our society and live in neighborhoods that are largely devoid of necessary health protective and health sustaining resources, the impact has been disproportionate. These upstream determinants of health, which created, perpetuated, and exacerbated these health inequities throughout the life course, we just talked about maternal mortality, infant mortality, throughout the life course, right, have to be addressed if we are ever to truly arrive at a more equitable and inclusive future for our most vulnerable people. So let's think about it this way, about the process of how a social determinant comes to be. By that I mean, you know, for every social determinant, there was a preceding political, legislative, or legal decision that yielded the result. City council orders, state and federal legislation, regulations, even legal decisions, all have consequences, both intended and unintended, that impact our health. They determine the extent of our lives, as we've been talking about, right? And the quality of life that we're going to have on this earth. This is what I'm calling the political determinants of health. So when you think about it in terms of history, the historical context. Almost 400 years ago, the early colonies had intentionally enacted laws to stifle Black and Indigenous populations from addressing their social determinants of health, prohibiting them from raising their own food, for instance, right? Learning to read and write, especially English, socializing and having acts and having to get passes if they wanted to congregate. We saw this throughout the early 1600s, not only with the legalization of slavery, but in terms of all of these policies that were created to stifle their abilities to not only survive, but thrive. You know, we've seen that impact from one century to the next. But even today, you can see the harm that even facially neutral policies have on Black communities across the nation. So think about, the Black communities across the country. You think about, whether you are in Chicago or New York or Baltimore or Miami or Atlanta, Detroit, Omaha, Nebraska, wherever you are, you'll oftentimes see this huge highway cutting through the middle of the Black neighborhood, right? You'll see parking lots where homes once stood, apartments or houses, right, in predominantly Black communities, which we know throughout time displaced over 500,000 African Americans alone. We've seen bus depots being built in these communities. If you look at Harlem in Manhattan, for instance, 6 of the 7 bus depots that are in that city were built in the Black community. Now, do we all believe that this was just the natural order of things that just happened? No. How did they come to be in the first place? That's what we need to be asking ourselves. And underlying every single one of these social determinants is a political instigator, right? These are your political determinants of health. So I think we need to do a better job helping folks to connect the social determinants of health to their political roots. And I think, what we have seen in this country, and I think what we've also seen during this time, especially, right, with the magnification of these inequities, is how one political determinant after another resulted in a continual tightening of a chokehold on these disparate communities. And then you look at it and you see the eventual disaster that brought to light the inequities that have been plaguing them. So when we think about all of these issues that we're dealing with, whether maternal mortality, as we've been talking about, whether obesity rates, diabetes, depression, and many other health issues, they can be firmly linked back to political action or inaction. And I think by understanding these political determinants of health, their origins, their impact, and their interconnection with the social determinants of health, we'll be better able or better equipped to develop and implement actionable solutions to close those health gaps. So I think if I had to synthesize this is how I envision the political determinants of health. I think they're really the most powerful instigator among the determinants.
I want to pick up on the 2 of those I words that you mentioned, although it looked like Dr. Gracia was going to say something.
Yeah, I was just gonna say one to how Daniel has framed this is an important framing to as we think about that movement upstream. And I know we've said that term upstream, and just ensuring that we're clear on what we mean by that movement upstream. At Trust for America's Health, we talk about the downstream in providing clinical care and meeting individual patient needs and ensuring that there's access to care and high quality care, to then moving to the midstream where you're actually also then addressing social needs and not just saying you need, you have this diagnosis and need this medication, but put a patient into context and really understanding, do they have access? Can they get to actually accessing care? Do they have housing insecurity or food insecurity? And then where we focus as our organization is moving as far upstream as possible to address exactly what Daniel was talking about, which is the conditions, and that those conditions are influenced by laws and policies and ordinances in each of the sectors, in education and housing and transportation. And so it then means that we have to move outside of our comfort area of being in one sector to then work in other sectors and partner with those sectors to understand what those health implications are. And that we also have to work in working with and educating and advocating to policymakers at all levels, from federal to local levels, to understand how those decisions are actually impacting health. We spend as a nation, over $3.5 trillion in health spending, but the large proportion of that is for healthcare. Less than 3% of it is for public health and prevention. And so these conditions that we're talking about, many of which are preventable, we don't have the investment. And then when we think about communities of color, we don't have, there is an even further disinvestment in many of these communities to actually build those conditions, to have the safety that we're talking about as it relates to bike lanes and safe transportation, to having the ability to be able to play in areas that are safe and healthy, to live in healthy housing. So tie that as well when we think about those policies and those laws, that's also tied then to think about the investment, because we also see that there's a chronic underinvestment in these types of upstream, really root cause types of policies that will help us towards achieving equity.
And I just have to jump in and say this one thing. In Chicago, on the south side of Chicago, a certain place, we're talking about place, you drive 7 miles or 9 miles, there's a 30-year difference in lifespan. Just 7 miles, 30-year difference.
And since we're all jumping in, I just wanted to add one more thing here, because we want to talk about solutions. And one thing that I teach in my class, actually my students are presenting it this week, is it's born, and I'll set some context. The Environmental Protection Agency, that agency was created in 1970, and along those lines, there was something baked in, this idea of environmental impact assessments. This idea that no matter what law is introduced, there's a quick decision of, is this going to potentially impact the environment? If yes, then we go through this assessment process to figure out what its impact is. And I'm a huge fan of health impact assessments. They've been used kind of across the world. There is some adoption here in the United States. Some public health agencies are using them, but really systematizing this process of understanding the unintended or sometimes intended health consequences of certain actions in every other sector. Because, as Dr. Satcher always said, health is in all policies, right? That idea that no matter what we're talking about, I see, okay, Inya just dropped that in the chat too. Health is in all of our policies. And so because of that, we have to have a process for assessing the health impact and specifically the impact on health equity, right? If this is going to drive bigger disparities, then we say, well, what are the mitigation strategies, or altogether, do we just not do this, right? And so I think that's an important part of our legislative process that has precedent in terms of the impact on the environment. I think it's something we can adopt here.
Well, let's stick with that theme, because I think what you're all alluding to, and Daniel, you talked about 2 I words that I think are significant to this conversation. You talked about inaction, and you talked about political instigators, right? And so usually in the policy realm, the conversation around health inequities or health disparities is often highly associated with one party over another, right? With the Democratic Party, it's usually considered a liberal agenda. Although when we're talking about health and the health of the nation, this has nothing to do with political standing, right? And so I'm wondering, across the board, and this is a question for all of you to please chime in on, how do you then get members who are not necessarily a part of one party compared to another to really invest in, to use Dr. Gracia's words, and value health in all policies and understanding the impact that policies, not necessarily squarely within health, but health in all policies from an equitable lens? What are some ways to navigate the political pitfalls of a 2-party or several party system, when really the outcome ought to be equity, and in this case we mean optimal health for all?
So
go on, Daniel.
You sure?
Everyone's so polite. I love you all. Go ahead.
I dare not go before the Congresswoman.
Congresswoman, please.
No, I say, serving on energy and commerce, one thing I did learn is that there are more bipartisan bills than people think that there are. And, my stance is healthcare is a human right. But, I think like my district is urban, suburban, and rural. As you get more rural, there are less Democrats, but they're suffering. They don't have, the broadband capacity that my urban and suburban have. So it's hard for them to do, telemedicine. The suicides are growing among farmers, and I have 1,200 farms, in my district. So I think there are more bipartisan bills than people think, but I think where the divide comes, in my opinion, is that they don't want to spend money. Like you bring up Medicaid, like the bill I was just finally able to get passed with maternal mortality and, incentivizing states to expand the Medicaid for a year. But, we had to water it down, to do that. But there have been like 21st century cures and some diabetes bills and things like that. But it really is building relationships, and particularly on energy and commerce, because it is very, very, difficult. And again, even though we do it maybe in the House, it didn't work, for the Senate. So, but it's tough. You're right. It is very tough.
Yeah, and just to piggyback on the Congresswoman's comment. So, when you think about advancing health equity, there's a reason why we've had a dearth of federal policies, right, addressing this issue. Yes, we've had some, but it's been really challenging. What I have seen in terms of the evidence, right, those that have been successful and have been not only created but implemented, passed and implemented, is that they were able to demonstrate the value of investing in change at the time. So in the US, advocates have to understand the disquieting and that harsh truth that the political determinants of health inequities, right, to your point earlier, Mia, have rarely been addressed unless their reduction or elimination served other purposes. How do you show from a standpoint, right? You can make a moral argument about 83,000 African Americans are dying each year owing to health disparities. You can say that till your tongue is bleeding, and that won't get a policy over the finish line at the federal level. But if you tie it, right, to an economic or a national security argument, those have been able to see the finish line, right, and get implemented. And that's true of every single one of these health equity focused policies that we've managed to get passed in the United States, from the Freedmen's Bureau Act all the way to the Affordable Care Act. It was because we were able to show that there was an economic argument, right? And that there was a national security interest in order to elevate this issue. So for instance, during the ACA negotiations, we took a lesson from 1946 with the mental health reformers, right? Where they were showing that 20% of young people were unfit for military service at that time, between the ages of 17 and 24. And 40% of young people were leaving the military in droves right during World War II. So as we were developing this, you sort of learn what has worked and what hasn't, which levers to push and pull. And in 2009, we were able, with the help of these retired generals and admirals, show that now 70% of young people were unfit for military service, owing to a host of issues, right? Dealing with these social determinants of health that we talked about. And so when you do that, it does help to strengthen your argument, and it gets the policymakers' attention. So always need to connect that effort, if they are palatable, to a commercial interest, and you have to show whether there's an investment value to the government. If you can do that, then your chances of getting that policy through increases significantly. Just something to think about.
Yeah, and 2 quick points to piggyback off of Daniel, at risk of talking, legislative history after Daniel Dawes. What I would say is that it hasn't always been the case that this is Democrats go it alone when it comes to health disparities. Look back just 20 years. Bill Frist was one of the leading sponsors of the Minority Health and Health Disparities Research and Education Act in 2000 that helped lead to the National Center on Minority Health Disparities, that helped lead to an Institutes of Medicine report that helped quantify our health disparities. And that was important work to do. And so I think there's just inviting colleagues to say, hey, we can make real progress. I think that's part of it. It's not going to be, again, you have to tie it to a compelling interest. And so the second point I was going to make is simply the realigning of incentives. And the reason why I'm such a big fan of kind of moving toward more value-based payment models in healthcare is because it realigns those incentives. Instead of talking purely about do more things, get paid more money, we're incentivizing health systems and practitioners to say, hey, achieve these outcomes as efficiently as possible, and that's how you get paid. And they start asking that question of, well, how do I achieve that efficiency? Well, often it's addressing social determinants of health. Right. And so what we're doing is we're realigning the practice of medicine in the United States to acknowledge and have awareness of those social determinants, to, as Daniel said earlier, pick up on that idea of collective impact. The collective impact role of hospitals and health systems, which are often the largest employer in a community, is enormous. And the potential for a real transformation is huge. Again, we just have to align the incentives to make that more possible.
I would echo what everyone has shared, just as some of the key lessons and strategies, and to Dr. Webb's last point, one of his points specifically with looking at it historically. I talked about, for example, the report on the Secretary's Task Force on Black and Minority Health. That report was done in a Republican administration. That was Secretary Heckler was serving in the Reagan administration. That was the leadership of tremendous trailblazers in health equity, such as Dr. Satcher and Dr. Sullivan, Dr. Haynes, Dr. Bowie and others who championed and really made the case in presenting the data to the secretary, as well as looking at the data that the department was already gathering and collecting to see the disparities that were existing, and that it was during a Republican administration that the HHS Office of Minority Health was created. Now, recognizing too, if you look at it legislatively, similar to what Dr. Webb and others have described, is that you try to really bring together the data with what Daniel talked about, is also making that case. Yes, there is the moral imperative, but there's a lot of traction and movement on it. Yes, we also need to make the economic imperative. And you see organizations, I mean, we had key reports that continue to be cited, like the Joint Center's work that articulated the $1.24 trillion, right, that we were seeing with regards to cost to the nation because of premature death and health disparities. The Kellogg Foundation, for example, that has put out reports on the business case for racial equity that goes sector by sector and talking about why really we as a nation, in order to really achieve our full potential and to reach the vital nature that our nation can play, we actually have to advance racial equity. So I think that it really entails ensuring that we're presenting all of those arguments and presenting why it's important to try to move these types of policies. And I agree with Congresswoman Kelly, there's more legislation than we know that actually does have bipartisan support. In social determinants, there's work that's being done. We're engaged in a bill that's currently in Congress on improving social determinants of Health Act that's gaining more and more traction in Congress with over 40 co-sponsors. The Congressional Hispanic Conference has just endorsed the bill. These are ways in which that if we can really present the case and show that our nation is not getting healthier, but we're paying more and we're paying, our healthcare costs are increasing, that these are strategies, investing in prevention, addressing health disparities and health inequities will actually help us in becoming a healthier nation and reducing healthcare costs, as well as ensuring that we have a productive and healthy workforce and families and communities that can thrive.
I get goosebumps just talking with you all the time. And it really just hastens my spirit. And I know Cameron probably feels the same way. Like, I mean, you all have preceded us in this work. And you sit before us, Daniel, Dr. Gracia, Congresswoman Kelly, as giants in this field. And I know that you looked upon people in the same way, right? And so Dr. Gracia, you just mentioned a couple of people. You mentioned Dr. Sullivan, you mentioned Dr. Satcher, Dr. Bowie. You talked about Secretary Heckler and all that she's done. Cameron mentioned Bill Frist, and as a Vanderbilt alum, shout out to Nashville. So I think about all of this. And to loop it back to a comment that Cameron made earlier, you talked about the pipeline. And I think Congresswoman Kelly, you also talked about diversifying the workforce. So I'm wondering, how do you all feel having observed people who have come before you, and you've taken up the lantern, and we watch what you all do. How do you feel about the pipeline right now? Are you hopeful? Are you concerned? What do you think about the future with respect to healthcare and all the things that we've discussed today?
Well, for me, with working with and MQF and all the 40 under 40s, and just, I'm older than all of you, so you're all the future to me. But just listening to Cameron, being around Mia, I mean, you just give me so much hope. I want to jump through the screen and hug you, actually. But I just feel so inspired, and I'm not sure how old some of the docs we have in Congress already. I don't know, they all look young to me, but, you guys inspire me so much, and I feel, so grateful and hopeful. But we need more of you, we need to find a way. I just spoke to, they weren't docs, but nurses at GW. And what they told me, that it was just so expensive for them to, become nurses. And my husband's a doctor. I know how much it costs. He's been a doctor for a long time. And I know how long it took him to pay off his school loans, and it's only gotten worse, and whether you're working on your PhD, it's just so expensive. So we have to find a way, and then we have to find a way to get young people interested. I mean, if you can't even go online, you know, you don't even have broadband capacity, you know, if you're not thinking about, you know, STEM careers, is just really tough. So we need you guys to go back into the to schools at a young age in high school to get people pumped up to look into these careers. But I mean, you guys inspire me so much. Like I said, you know, I already have plans for Cameron, so you know, I'm in good shape.
Well, picking up on that, I think I tell the story all the time. I'm a doctor today because of my physician, our primary care physician, when I was 4 years old. His name is Dr. Timothy Yarborough. And at the time, he was a young Black man in his mid-30s who was just a couple years out of residency. But, you know, in the mentorship space, we say you can't be what you don't see. And so seeing Dr. Yarborough serving in our community in that way, it inspired my sense of how I wanted to serve. I wrote about that in my, you know, personal statement for medical school. I talked about Dr. Yarborough and just the impact of, you know, then, you know, almost 20 years later, having seen a Black man as my provider early on. And we know that, you know, there's a dearth of Black men in medicine. You know, there was the National Academy of Medicine's report just a couple of years back. And I see a lot of the folks who are who are participants in today's call, a lot of our colleagues and friends from the NMA were part of that conversation, really figuring out, well, how do we strengthen that pipeline? And I think the reality is, as in most spaces in America, Black women have been holding us down. And I think that it's important for us to note that as that has gone, you know, it's been important for the health of Black communities to have the number of Black women physicians really leading the way. But we have to continue to do better. The educational inequalities we're seeing today, the educational disparities we're seeing today, even worsened by COVID, I should note, those are going to be impacting our pipeline of tomorrow. So we have to keep in mind on that, you know, and you mentioned a lot of the other core issues. So I think that it's so important that, you know, as we say, representation matters, and it's important that people see it. People ask me all the time, why do I have Dr. Cameron Webb on all my campaign materials? They're just like, you're not running for doctor. And I'm just like, every Black child in this district is gonna see me as Dr. Webb. What questions do you have? You know, and I think it's important that we step into those spaces and show people what it looks like, what representation is, particularly as physicians of color.
Me, I would say that I certainly am very optimistic, and just, you know, in asking why and why is that is because of what I see each and every day and what I hear each and every day from students and trainees, those who come in as interns. It's shifted from, and Dr. Webb talked about this with regards to the courses that he teaches at the University of Virginia, is the expectation actually that we should be addressing equity, the expectation that we should be thinking about working across sectors and really addressing root causes, that expectation is also changing. And we know that so many of the movements, when we look back historically, so many of the movements, whether it's civil rights movements or others, have been driven by students. And so seeing that and hearing that, and that's really a transformation from, you know, what we may have experienced during the time of our education and training, certainly gives me hope and motivation for doing this, is because I have benefited from the investment that others have made in me and that continue to invest in me. And so I think that we see it as our obligation to continue to give back and support the pipeline. And as Dr. Webb noted, that it's the mentorship, and it's also addressing these inequities in the systems that we see with regards to education, where also we can see that with regards to educational policies such as suspensions and expulsions that are disproportionately impacting students of color, starting as early as preschool, where the students of color are being suspended and expelled really for what should be considered normal childhood behavior, or something that teachers should be able to address. We have to look at those types of policies to ensure that that pipeline really isn't being disrupted because we have inequitable policies that are actually preventing students from being able to achieve these types of career paths.
Yeah, and ditto all that has been said. I would just say that, you know, in a recent conversation that I had with Ambassador Andrew Young, and talking about, you know, the differences between what he witnessed in the civil rights movement and what we see right now within this movement, right, with BLM. It's as if we have this really great awakening that's happening, right? One in which I think with these millennials, they are a force to be reckoned with. And I think Dr. Gracia, when she mentioned that there is this expectation, I don't know if we've had that very recently. There is that expectation that equity should be centered in everything, right? In the entire curriculum and how we look at, you know, our society, and chipping away at these concrete concretized inequities in society, wanting to really drill down deeply at the root causes. And it's something that has been inspirational for me and has given me a lot of hope. I usually am a person who sees the cup runneth over, but lately I've been seeing that glass closer and closer to being half empty, right? But with the millennials, with what I see happening right now, that is giving me hope, and my cup is starting to run over again. So I'm really pleased with the direction that they're leading us.
Well, on behalf of millennials, we appreciate you all. Thank you so much. So we have 3 minutes before the close, and I can't believe an hour and 15 has gone by so quickly, and I'm quite sad, but I am going to invite you all to just give us closing remarks. What do you want us to take away from this conversation as we move throughout our day? I'm going to call on Cameron to start us out. Go ahead, Dr. Webb.
Perfect. Yeah, so I think conversations like these are so important because they give us an opportunity to hear where we've been, where we are, and hopefully where we're going. And so I'm always encouraged by hearing some of the leaders and the folks who I've looked to in this space. But I think that, what it reminds me of is how many people it took to build on Dr. King's words that of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. So build on that language to ultimately get us to the Heckler Report, and ultimately get us to unequal treatment, and ultimately get us to the Affordable Care Act. That arc of history really is built by a lot of hard work, a lot of people pulling to make it happen. And so I'm encouraged, I'm inspired. I'm always thinking of, well, what's my part, what's my role to play in continuing this progress? And so I love these meetings, these events, they're energizing for me. And just thanks for the invitation. But to everybody, all the participants, we got a lot of work to do. So let's keep going.
Well, I'll go next. And I think the good news from what we've heard today is that, these structural barriers and the resulting inequities that we've been experiencing are not permanent. But it's going to take greater action and collective agreement, as Dr. Webb just mentioned, right? From individuals, from all of us, committed to stomping out inequities, to formulate and execute the strategies and the policies that will help us overcome them. In the few instances in which we were able to realize health equity focused policies, their tenure was short-lived, right? Once opponents of health equity secured power, the political pendulum swung back to unravel those gains that we were able to achieve over the centuries in this country. And I hope that is not just a moment, but it will continue to manifest in a movement to elevate health equity in a manner that's going to positively impact our communities. And I think only then will we be able to move from a partial commitment to equality to a full commitment to equality in health.
So I certainly want to give the last word to Representative Kelly to close us out. So I will just say that since we have been tying history, this conversation also reminds me of a time when I was at an anniversary event, of the signing of the Emancipation Proclamation, and a historian said that history is really like a series of punctuation points, like when you toss a stone into the pond and you see these ripples. And at that time, there was that punctuation point. And I think we're in a punctuation point again. For us to really take, in particular, we talked about the pandemics, the triple pandemics, the pandemics that are impacting people of color, communities of color, that we can take this time to really seize this moment, to see that transformative change. And that's going to take leadership, committed leadership to equity, to the centering of equity. It's going to take sustained investment in really rooting out these causes and structural inequities that we see that have been longstanding drivers of inequities in health and across systems. And that it means that we also meaningfully and substantially engage with communities and listen to communities, because they have solutions and ideas that they need to be at the table, and that we have a role to play, from policymakers to the private sector to others, in really achieving health equity for our nation.
I just wanted to thank all of you so much. Thank you for being a part of the Kelly Report. And I want all of you to be able to come and present to Congress, whether it's the working group or whether it's Energy and Commerce. I think it'll help so much, because people need to learn we all do better when we all do better. So just thank you all so much. Cameron and I will be there waiting for you next session. But I would really love if you could come and present, especially to the working group, because this has been such a fruitful, productive, and I learned something all the time from you guys. So I just want to thank you again and thank Mia, who's done a marvelous job.
Well, thank you, Congresswoman. And I'll just say, you all have said all the words, but again, I'm truly empowered and inspired by all that you all are doing in your spheres, but then collectively what we're able to do together is just, it's powerful. So let's keep up the work, stay hydrated, stay rested. I hope your families are well. Keep your head strong and high, but know that you can lean on, we can lean on one another. And so I'll just say thank you so very much to the National Minority Equality Forum for this platform, for putting this together. And I'm Mia Keys. I'm with the American Medical Association Center for Health Equity, but I wouldn't be where I am or tackling the issues that I care so much about had it not been for literally everybody on this call. So thank you so very much. And we will go ahead and shoot it back over to NMQF for the next session. Make sure you all tune in.